Good morning, everybody. Welcome back for day 2. We're really excited to have you back for day 2. I'm going to admit this is my favorite day out of this learning session. But the first thing is, how are you feeling about the room temperature? Better. Better. If it's good, raise your hand. Okay. If it's too hot, raise your hand. Too cold, raise your hand. Okay. I feel like, unfortunately, we're about as middle ground as we're going to get. Just so you know, I think Laura Wando personally asked like 4 times yesterday, so sorry it didn't happen, but hopefully today will be better. Otherwise, today's really exciting. We're going to do a lot of activities, but we also want to, for those of you, this is your first learning session, this morning piece is where we reflect on questions that you sent in or things that we saw or things that you put forward in your feedback. So then fast forward to the end of today. If you give us recommendations or ask us questions, we will do our best to bring those back to you. Some of them are going to be today, and some of them are going to be in the future. But that's what we're trying to do this morning. So I just wanted to really quickly say a big thank you to Julie Stagg, because every time we do that, she gives us a deadline for when we need to give all of our new slides to address what you guys have done. And without fail, that deadline is like 3 a.m., 4 a.m., and that's because she works all night the night before trying to put it together. So everybody, quick round of applause for Julie. Thank you for everything you do. By the way, that's not just today, that's every day. Okay. So here are the list of things that we saw that you guys brought forward. We also really quickly just wanted to say what we heard you talk about from the data session, and Mindy's going to kind of bring that forward to let you know what we, is that still okay? What we heard so that you guys hear it as well. And then there are a few things from prior learning sessions that we wanted to let you know we heard from them. That we'll be bringing in action period calls or in requests and toolkits and things like that. So that we're doing that so if there are things you want to add to that list, you know you can, and either come by and tell us or send it in your feedback form. All right, so this was the list of lingering questions from you all, and I'm going to first turn it over to Eleni. Eleni, do you need a mic? You got one, perfect. Okay, you want to tell me when you want me to advance your slides? Perfect. All right, Eleni's going to talk about many questions about patient integration, how you include a patient in your quality improvement process, many other questions. What do you need, Eleni?
Yeah, no, I'm just, the ongoing saga of slides that don't translate the way you intended them to. Okay, so a couple of things that I just wanted to, because we heard, one of the things that struck me in your introductions yesterday was how many of you are really interested, like your ask was, how do we integrate patients into this QI work? And we'll certainly be talking more about this. There have been some action period activity and training around that in the last session. I have no doubt there's going to be more in the coming session. I wanted to talk specifically about a resource that is a program of the Preeclampsia Foundation called Mama's Voices that is available to you, like it's actually part of this whole collaborative experience. And that is really 3 components to it. One is we are here to help train patients that you may identify. And when I say train, really what I mean is that we prepare them so that the panelists that you saw yesterday, they're not just fresh off their experience and they just show up and like, let me tell my story. There's a lot of preparation that we do with them to make sure that they're emotionally ready, that they have their story thought through, and that they're bringing it forward in a way that is helpful to you all, and that they're really here for the right reasons. I mentioned this yesterday, that they're really here for the right reasons. So we're here to help you do that at your hospitals too. You may identify patients and think, oh, this might be a good person to work with. So send them to us, and that's what the QR code is for. If you want to take a picture of the QR code and send that to your patients, that's for them to go through our training. We can also do that through recruitment that we've done. We've been doing a lot of recruitment in Texas for patients who want to work with you all. It's very possible we already have patients in our database who are in your area. They may or may not have been at your particular hospital, but they're in your area, and they're ready and willing and able to work with you all. So finding patient-family partners is part of what we're doing for you all. The second piece that we're doing for you is training you how to work with these patients. It's not, yeah, raise your hand and yeah, I want to do this, and it's intuitive how to do it. So there is some training associated with that, which we're prepared to do more of because we've already done some of it during the last action period. And then the last thing is the matchmaking, right? Finding the right patients for your facility or for the issues that you're addressing. I wasn't planning on doing this. We talked briefly about this, but Jennifer, I'm going to ask, would you mind? Can we run a microphone over to you to talk a little bit about what you guys are doing? So we had our annual or biennial Patient Family Summit last weekend. And it is open to providers who want to come. And one of your colleagues came and experienced that and also has done a lot of thinking around patient-family engagement. So I'm going to ask you to talk a little bit about your experience and how you're thinking about this process.
So I guess the first learning session in January, it really struck me just hearing patients talk about their experience, and then found out about Mama's Voices. So I had the opportunity from work to go to this conference a few weeks ago, and it was very heavy, but really good to just really listen to patients, what they experienced. I mean, we're a low-risk facility, so we don't see some of the things, but a lot. I went there initially because we had a hemorrhage, and a dad was like, I think I need some help. I was like, okay, I'm resourceful, let me find you some help. And there really wasn't much I could find for him. So I went there in the hopes to find partner, spouse, some kind of support if there was something there for it. And one of the speakers talked about that and how her spouse really needed support, and just the strain that it put on everything. So I feel like that just kind of really sat with me, like, what are we doing? And yesterday in the simulation, we were talking about the families around. What are we doing for the families? What are we doing for the spouse support? So I was talking with Eleni about trying to start something to support those dads, partners, whoever is affected. It could start there and then go to, the rest of the family or whoever's involved. But if you have a chance to join Mama's Voices or get involved, it wasn't a normal conference that I'm used to going to. It was a lot, but it was really good. And I just...
It's probably the only conference you'll ever go to that has a wellness room for people to be able to get away and decompress, and
yeah,
it was a lovely setting. What's something specific that you all are thinking about doing, even if you're not necessarily going to implement it? What are some of the ideas you've thought of?
So I think, in Mama's Voices, Shad and you were talking about doing, prepping families in a way that's not scary about outcomes or things that can happen. So we were thinking of, there's a few people even at work whose husbands may need this too, but even presenting something in our childbirth class, like a little part of it of these are scary things that can happen, but these are some things that are in place. So engaging whoever would want to, as far as partners or spouses, if anybody has one, to kind of start it and have them really lead it, not really, a nurse telling them what they should do, but what they need for it. Especially, there's some men in here, but sometimes they process things a little different than women, and
sometimes
and it shows up in different ways. So things that, and I feel like bringing in people who understand that, aka partners, men, will help kind of lead that too. So just some thoughts on what to do.
What I really like about that is, and as you all are thinking about this, is you don't have to, it's project specific, which means then you're going out and looking for specific people. In this case, like the supportive partners, you know you want to try preparing a program for the families. So this doesn't, all of this engagement doesn't have to be forever. It can also be very project specific. Like if there's some particular thing at your facility that you really want to explore and you really do need and want patient engagement in developing that project, then go out and look for the specific patients who are going to help, who have some experience with that thing that you want to address. There are more long-term things that you can do, like developing patient advisory councils or patient advisory groups. I think a few people have mentioned more bedside things like leader rounding at the bedside, and I think the only thing I would mention about that is really make sure that it is explicitly not staff and somebody who can really say this is not, you know, trying to create that environment that the patient can speak very openly about their experience and not feel like they're getting somebody in trouble, which will be a bit of a wet blanket on any comments they might have. Discharge phone calls have been brought up as another way, another approach to gathering patient involvement. Other things that I wanted to bring to your attention, this is a little bit more involved, but doing something like a town hall, and that doesn't necessarily have to be at your hospital. It could be you going into your community and maybe specific aspects of your community where you really want to engage their input. And then the last thing that I wanted to bring to your attention is there's some really fascinating work coming out of California, and it's not live. There's a recording of a webinar that's going to go online, and I'll make sure that the staff gets that out to you through Basecamp when it goes live. But one of the people that's really spearheaded patient-reported outcomes work is a doctor by the name of Kim Gregory out of California. And she's done some really great work validating patient-reported outcomes and has some tools for how you can use that to collect patient input. Recognizing that the HCAP surveys, A, rarely get done, but B, they're not maternity specific. And so there is a lot of work coming out of California that we want to try to repurpose and bring to you all as ways to really engage patient feedback, patient input. So, so look for more on that. The last thing I'm going to say is this afternoon there is the community resource tables that you all are going to round on. I unfortunately am not going to be able to staff the Mama's Voices storyboard table like I usually do. I've got another meeting I have to go to. But I'm going to encourage you to not skip that table when you do the rounds, because I did put on the storyboard the most common questions we get from you all and some answers. So take a moment to actually read the storyboard, and you can ooh and ah of the jewels that I put on it. But more importantly, look at the content of it, and there are several QR codes that you can follow. There's an email address on there for more information, so use it. Take a moment to just gather around the storyboard as a group and take a look at what's on there. And I will leave it at that. Thank you.
Thank you, Eleni. Anybody have anything they want to ask or comment on before we switch topics? Okay. Mindy's going to tell you what we mentioned or some of the discussion that happened in the data session for those of you who weren't there. But we also, if there are things you want us to know that's going to help with data collection, because we do see, and we want to make sure you know we see that reporting has been a challenge and is lower than it was previously. And so what we're really looking for is what you need to be able to submit data so that you can use it to improve in your hospital, and we can use it to improve overall at the state level. Go ahead, Mindy.
Okay, hi. So thanks for those of you that came out at 7 this morning and had a fun data talk with us. Those, you know, now I look around the room, I can see who my data passion people are. There's a few of us in here. So one thing that came, I think the biggest aha of the morning was the family of measures form that really describes each measure, and that is super helpful for each of you. So it kind of was like a big in the room. And that family of measures form is in the data folder.
Data resources folder is what it's called.
Resources folder, yes. Data resources folder.
Which you can just search for at the top of
Yes.
Basecamp to get you directly there.
Yeah, there's a search field, and we're going to try to put it somewhere a little bit more accessible. We heard feedback this morning that it's a little bit buried, and it's so important that we need to pull it out from the depths and somewhere. But it's also linked in the emails that are being sent to you. So look for that. But it doesn't, the title of it, we also kind of understand now, maybe doesn't describe or put forward the importance of it. So it's the family of measures, and it's very important if you are still kind of struggling with some of the measures. Let's see what else came of it. We had great information about a large amount of you from this cohort are disaggregating data, so congratulations on that. And but we also hear that a lot of you are kind of at step one, and that's okay. We really want you to ask your questions, and it was some very honest conversations this morning and awesome feedback that will help us grow. And so we take that as a win. We hope that you can continue having those very honest conversations with us and letting us know what you need. Julie is willing to meet with everyone, as needed, one-on-one for a quick 30-minute call. Everyone, not each team. For a quick 30-minute to walk you through. If you really are still struggling, I saw her do a one-on-one yesterday afternoon, and so that is really helpful. There is a PDF available of the data, the Qualtrics form. So we heard that some people still like pen and paper, and they want to fill it out ahead of time, and then go online and enter what they have written down on the paper. So we also heard that it'd be nice to have a digital version of that form. So you can kind of digitally fill it in as you work, and then when you get online, you can enter everything at once. Great question about the form. You have to fill it out and submit it all in one setting. So if you leave the site, it will not automatically save your information, just as an FYI. We're also looking for ways for some forms you see it says submit partially completed, come back later, or save for now or something. We're looking at that, but for right now, you need to do it all in one setting. Sit down, fill it all the way out, and put submit at the end. Forgetting any other points? Oh, the information, the numerator and denominator descriptions, the codes.
That's in the family of measures form, and then there are links to the SMM codes from it.
Yes.
So the things that are in that data resources folder that hopefully should help you guys are there's a data guide with a little bit of how-to. There's the family of measures, which is the numerator denominator and has links to the severe maternal morbidity codes and the codes for the denominator of the severe maternal morbidity in women with hypertension denominator. And there are the 3 webinars that we did earlier, kind of walking through the Qualtrics form and some specifics of the measures. But we want to bring you more data-oriented calls, maybe January-ish. So if there are things that would specifically help you, let us know. And then we also heard things that would help you all, like some toolkits surrounding working with your admitting staff for kind of how to train them and script and make sure the way they are assessing and putting into your electronic medical record race and ethnicity and payer and language is gold standard and is done in a way that you can trust your disaggregated data. So we will work on that and also link to some other toolkits that already exist. We also heard prioritization of the measures. So if you're only able to collect a few, you guys know which ones we recommend as the most important. You don't have to submit when the deadline is. There's no penalty to being a month behind. So if your data reports come in a month behind, that's fine. Submit them a month behind. That's your schedule. There's no true deadline there. And then just a few other resources and things that folks need. So again, if there's anything else that you want to share right now, and Julie and Jamie, anything you want to add to that from things from the data call?
One thing about coding. This aha moment for me about 3 years ago, that I realized I had to understand and know codes. It wasn't taught to me in nursing school. I don't know if it was taught to any of you guys in this room, but I didn't learn about coding and codes and how to understand all of that, but that's kind of where we're at. And, you know, if you're in this room and you're a leader, you need to understand coding and codes and have a good relationship with your quality department to let them fully understand it, but you need to know enough to ask the questions when your reports come out. This is reportable data, and you need to make sure it's, you know, a lot of this is getting coded correctly.
In that, those data measure calls that are in that data resource folder, call number 1, Kendra and I go through point by point how we did that within our hospitals, if you guys ever want to go back and reference it, and how you validate codes and where they come from and things like that. Now, everybody's system might be a little different, so it's just 2 different examples of 2 different hospital teams. Anything else? Anything else you want us to know that would help you? Because again, this is quality improvement, so we will internally adapt to help you all improve as well. So we go through the same PDSA cycles and adjustments. So let us know.
The charts and graphs are coming.
Oh, yes. So hopefully in the near future, we will be able to bring back, for those of you who are reporting, and for everybody else. So for those of you who are reporting, what your data has looked like, what you look like in comparison to the rest of hospital teams that are reporting, and for all of us, just how we're doing as a collaborative in those of you who are reporting, as charts and graphs and ways that can kind of, number 1, you can bring to your leadership and show why you need resources and effort and where you are, and number 2, so we can see what we need to focus on for the second half of this collaborative. So with that, quick thanks to the table of folks in the back of the room, not only for all of the data pieces, but for everything that goes into this learning session. So in the back, really quick, is Laura, Ricardo, Maria, and Nika, who have put all that together. All right, Jenny's going to talk. One of the questions was, what are more ideas for outreach? So we're going to add our interpretation to that question and share some things. Jenny's doing it from the lens of being a level 1 hospital and what she feels level 1 or 2 might need, and some examples. And if you guys are doing something exemplary, please feel free to add in.
I think I have a couple of slides. So we are about 45 minutes away from 2 level 4 facilities. And so as a 3 and 4, they're supposed to do outreach to all of us, right? We get great outreach from our NICU partners. They do webinars. Our sister hospital in our system has somebody that does outreach. She's part of their transport team. So we see her often. She frequently asks me what we need. And so when my nursing staff expressed kind of some hesitancy and not really comfortable with just basic NRP resuscitation, and because we got blenders and T-pieces about 18 months ago, we really pushed that education out to our staff, and she is coming out monthly and just setting up all of her equipment with a couple of different mannequins, supplies, and brings all that to us and sets up, and we'll just run whatever NRP simulations the staff say they need. It's just kind of come and go for a couple of hours, and it's been really helpful in helping my caregivers just be more comfortable with that initial resuscitation when the babies just don't want to live. So that's been really, really helpful, because as a level 1, of course, we're going to ship anything that's less than 35 weeks, ahead of time if we can. We're going to call them to come and be at delivery if we can get them there. So it's just not something, when we do 35 deliveries a month, it's not something that every single caregiver gets enough practice with to be really comfortable with it. And so that's been really helpful. And then, of course, we all have lots of new nurses. I have new grads that work in labor and delivery and in the nursery. So it's really helpful for them to get that somebody besides me giving them education and helping them kind of work through some different scenarios. So that's been really helpful. She also has been doing in-person stable classes. We can do stable on HealthStream, but it's just not the same as having somebody there that can that you can ask questions with. Our physicians also participate in these. They will come to stable classes, they'll come to the NRP drills. And in fact, we had several planned in the summer, and the very last one, I had 2 physicians that they had planned on coming to that one, and the NICU transport person was ill, and we had to cancel, and they were so disappointed, and they kept after me to reschedule them. They were like, we want to do this. So that was great. She also came out a couple of weeks ago and did a physician-specific outreach and brought equipment to do to practice placing UVCs. And so we kept little pieces of cords, and she had this great setup with little baby bottles where they could practice placing UVCs, because that's also something they hardly ever do, but when we need it, we need it. And so that was really helpful. And then they also did some intubation. We're introducing LMAs because that's not something we've had previously. And so that's been just really great to know that if I have a need, I can reach out to her and say, hey, can you do X? And she gladly says yes. We also had RTs that weren't quite on board with the blenders and the T-pieces. They really liked their bag valve masks. And so she brought RTs from their transport team to help get them more comfortable and speak their language. So I know that's all NICU and newborn, but that really helped us. From an OB perspective, we don't get as much outreach, and it shows. The 2 level 4s, the same 2 level 4s, have done some webinars and some great, you can join this webinar and get this hour of CME or CNE. But they don't visit and they don't ask. And so some things that, and then they've also sent their lactation consultant out once to do a class with the nurses. The next slide. So some things that would be really helpful for us as when you're thinking about, as a level 3 or level 4, reaching out to your 1s and 2s, I struggle with physicians who want to hear from physicians. I can say it all day long. This is how we should treat hypertension. This is what this fetal heart rate strip looks like, and this is what it means. But really, a lot of times they still want to hear from physicians. And so, like, I had a physician approach me about 6 months ago asking for us to do strip reviews, just monthly, every other month. Let's look at this case and review strips. And I said, I just got my certification. I would love to do that for you. And she was like, well, I would really love to hear it from an MFM. And I was like, okay. And I haven't been able to make that happen because of just a lack of involvement. I also think it would be helpful to, as they're thinking about their policy development for AFE, for placenta accreta spectrum disorders, for eclampsia, hypertension, HELP syndrome, then kind of filtering that down to us to help us understand what our role is in that, because obviously a lot of those patients we're going to transfer to them. So helping us develop our policies so that then we can be a partner with them to support that patient until we get them to them. And even patients that we're transferring that are just in preterm labor. I was telling a physician about 2 years ago, hey, we should maybe think about a mag load for this patient for neuroprotection. And that was not something she was familiar with. And so just different things like that I felt like they could really benefit from. And then, of course, the same kinds of things that our NICU partners do for us, like simulations. It's difficult for me. I'm a one-man show to do everything. And yes, I have nurses that work in my department that are helpful. I have 2 NRP instructors. I have 3 fetal heart rate monitor instructors. But we're providing that education for our region because they're interested in doing it. And we're not really getting much back on the OB side for regional education. So really anything that you're doing as a level 4 or a level 3 for your staff would be great to roll out, maybe in a different way, but to really reach out to your transferring partners and get them in the loop of, this is how we do things. Can we help you, loop you into kind of some extra education for your staff?
So for those of you that are level 3 or 4, this was a level 1 telling you what they need.
A lot.
And how you would help meet it. Some of that is an hour, some of it is longer, but this is the kind of thing that they need for outreach and critically important to improvement in our state. Thank you. All right, Rocky, we got a question of how do you get physicians to treat severe hypertension? So she was going to give some tips and tricks. You had big asks.
It's always my favorite place to be as a physician is like, your physicians don't do anything. How many of you have a hypertensive crisis protocol? How many of you have trained your nurses to run the hypertensive protocol? They know it cold, right? Yeah. How many of you struggle to get your physicians to follow the hypertensive protocol? Right, so everybody knows it except for the physicians, and you're relying on them to give you that order, right, and follow it so that when you do your review process, you're not like, well, we tried, but... So, my facility struggled with this too. I'm a level 3 facility, and I was like, I don't understand. Like, I understand it. Why can't everybody else get with the program? So we started by changing our order sets in Epic. So our order set is not just the, labetalol, the hydralazine, and the precardia, but it actually goes through in the order set how far apart your blood pressures should be when you return to normal blood pressures, what that looks like in the afterward in terms of monitoring. So I thought, well, that's definitely going to fix the problem. Yeah, that didn't fix the problem. So I've started working with our nurses to change how we ask or make her ask. For us, it's in scripting, and this seems to have landed us in a much better place. So when we have a patient who has triggered a hypertensive crisis, and we should be in our facility using this protocol, the phone call that goes to the physician isn't, we have a hypertensive crisis, what would you like to do? It is, we have a hypertensive crisis, it triggered the protocol. Do you want to choose, which of these 3 medicines are you going to choose? And the order is for the protocol. We ask for the order for the protocol for these 3 meds. We don't ask what, a one-time order or anything like that. It is, do you want to choose the labetalol, hydralazine, or a precardia protocol? Physicians take the path of least resistance, quite honestly. If you give them too much room to think, they're like, well, I maybe should do this, or maybe I should do that. So we just removed that thought process and just said, here are the 3 things. Or if she doesn't have an IV, we lead with that. She doesn't have an IV, so we plan on using precardia if you're okay with that, the precardia protocol. Great, go down that pathway. So it still does give them a choice of what medicines to use, right? So they can, but every patient, no matter what medicine you're going to use, they're going to follow a particular protocol with follow-up blood pressures and so forth. And then the follow-up question after we had the order is, do you want us to call you if she continues down the protocol, or do you want us to call you at the end and just give you a summary of what happened? So it's in our ask and not so much in it, but I think the order set is super helpful in being very descriptive. It's not just this is our unit protocol and it's written on the wall somewhere. It's actually in the order set, and then just how we ask for it.
And I just want to highlight some of the reasons why that's helpful is at least speaking as a physician, it's not necessarily because we don't want to do it, but if you work in 4 different hospitals, sometimes when you get a call at 2 a.m., it's really hard to remember what the protocol is for hospital A that's calling you. Keep in mind also, sometimes if they're not like 24/7 in-house, you might have woken them up when they had worked all day, had gotten 12 other phone calls at night, and are going to work the whole next day. So I can't tell you how many times in my life I have woken up standing in the middle of my living room on a phone call with somebody, and I have absolutely no idea what the first few sentences I said were because I was dead asleep. So I think just packaging it in that way, if you end with what do you want to do, then they have to go through that whole thought process. But if you have a protocol, what you're actually calling is, I'm initiating the protocol, which one do you want? So I think that phrasing, at least for my brain in the middle of the night, helps a ton.
And just to give you a perspective of how it changed for my hospital, we were meeting compliance at about 30% every single month. It was really sad for me reporting that on copy every month. And we knew where our problem was, we just didn't know how to fix it. When we made this, as we started to make this alteration, and I went to physicians individually and ran through a 5-minute simulation, a nurse is calling you in the office, here's her phrasing, I just need you to respond with one of these. They were like, great. The next month, it popped up to 90+%, and we've maintained over 90%, except for 1 month we hit 89%. But it really was, I think in our phrasing, we'd had the protocol out for a while.
All right, one more thing, and then we're going to go forward so we don't run out of time.
Ours is a hard stop for every patient that's admitted. Every patient that is admitted to our unit, labor and delivery and mom baby, in the order set is the protocol, and it's a hard stop. If they trigger, yes, but the orders are already there. They have to add something. They get to choose the med, but it's a hard stop, and they have to add something. But the whole protocol is there.
Thank you. Okay, a couple of other things, and I'm going to breeze through this so we can get to, I think you're like 15 minutes, is that right? Okay, got it. You guys had so many wonderful questions. I'm going to fast forward a little bit. One of the things that came up in the patient panel was folks talking about specific resources for reproductive health-oriented directed expertise in behavioral health support. So I just wanted to remind folks that PeriPan now exists and has statewide coverage. That's the phone number to call. You can all do it if you don't have access to somebody who has perinatal mental health support. And if you have more questions, we'll go through it. This will now be available on Basecamp. But it also includes, they do grand rounds. They have a great grand round schedule coming up where you can go and see information, and then they're doing an echo type thing where it's kind of a train the trainer spread statewide. All you have to do is sign up, and it can be as easy as, like we just said, all right, we want to add every provider in our hospital system, and boom, they were all added and we all had access. It was very easy. Okay. This one? All right. Got it? It'll be in the Basecamp. Okay. I think we got a little bit different order. Things that we heard from other teams that we are going to bring forward in the future, a lot more about how you adapt your protocols to have a trauma-informed care lens and the specifics of that. We're going to do a social determinants of health-related SIM in the afternoon, and lots of questions have come forward, especially as CMS is really requiring us all to start doing this. How do you effectively and compassionately screen for social determinants of health, and what's some best practice surrounding that? A lot that we've seen in SIMs regarding making sure everybody kind of understands your level of responsibility in transfer and transport, which is if you're transporting out, you have full responsibility until they walk in the hospital door of the other hospital. So you need to make sure they're transporting with magnesium, they are treating their severe hypertension, all of that. So I think we're going to try to bring that forward in December. And then pieces about training your admitting staff to help you all with disaggregation. If there are other things that you want to see in action period calls, let us know. And then these were all the toolkits that folks have asked, including like how do you hand off to new team members so they get oriented to AIM? So those are things we will work on. How do we package information from these learning sessions so that you have a sort of slide deck or something you can bring back to your hospital teams when they couldn't all come? And then many folks have asked that the simulations that we will do today, how you can bring them back to your team, so we will package them so that that's possible. Lots and lots of questions about readmission. I'm going to try to spend 5 minutes going through this, but I'm happy to keep talking about it. We are all happy to. There is an action period call on the postpartum visit as well that you can go back and reference, and a lot of this, I'm going to admit, is things we've presented there before. So there was a question, what do you do with a 72-hour follow-up if the patient is discharged Thursday or through the weekend? So this publication that's highlighted at the bottom, including authored by our own Jamie Morgan, talks about that measure and some best practice things surrounding it. Jamie, sorry, I'm presenting what you published. Feel free to jump in. But a couple of things. It includes inpatient, telehealth, phone call visits, all as various venues that you can successfully do this. Yes, an in-person visit is much more probably impactful than a telephonic visit, but if your patient doesn't have transportation or doesn't have insurance or didn't have prenatal care somewhere, at least do the phone call. All of those things capture the goal, which is checking their blood pressure, which might mean you need to have given them a cuff, and seeing if they have symptoms to know if you need to help manage that, readmit, initiate medications, et cetera. So all of those things count. Somebody asked for codes that you can use and billing charges. That's coming in a minute. Alternatives that they suggest in this. So number one, if they deliver on a Thursday, bring them back on a Friday. You don't have to do 72 hours. It's within 72 hours. You can bring them back to your triage unit. You can develop a postpartum follow-up type clinic. And I'm going to give you some examples. People ask for like FTEs and how to create it. We'll go through that in a second. I'm going to breeze through it in the interest of time, but it will live on Basecamp and you can pull it all down. And they give other kind of tips and tricks of how you might be able to do this. There are probably not one right setting for a hospital. You probably have to come up with options. So in that social determinants of health, SIM, there are a ton of different options for postpartum follow-up. This is us bringing examples of that to you so you can see different ways to implement it, including home visits. Lots of novel ideas. Okay, somebody asked, how do you implement a hospital-based follow-up clinic? So look at what's going on in your system already. We just started this in ours. We have a follow-up lactation clinic. We added follow-up for hypertension to that clinic. We applied for a grant within my hospital system. I asked for 4.5 FTEs for nursing. That's the entire funding for that program. If you don't want to do 24/7, you might just need 2.0 FTEs to staff from 8 to 5. Whatever you want to start with is helpful, and then you can build from there. Needs that you need to do this sort of clinic. You need people trained to know what they're doing. So again, it's a nurse doing this in our clinic, which means we have to have a protocol for escalation. If the blood pressure is high, what do they do? If the patient has symptoms, what do they do? So we created all of those, which are going to be available on Basecamp for you. But you need to train them to have a way to check the blood pressure, ask for symptoms, and what documentation looks like. And I say that because we did all that, and then it would just say, patient seen, and they didn't put in the blood pressure. So just so you don't make the same mistake I did, you have to train them what you want as documentation. Make a dot phrase, populate it for them, script it, whatever. These are things to make this successful. People asked what the billing codes were. Here are billing codes that you can use. It is not part of global charges because it is in a high-risk patient. The red codes that I have highlighted are nursing-only codes. Again, you can use it, you can bill for it. It depends what code you need to use, what your clinic is registered as. Is it an outpatient? Is it an emergency department? These codes come from that publication I just showed you from SMFM if you want to go back and reference it as well. There was a question about reducing readmissions. Brooke, I'm not going to make it. I'm trying. Okay. So that's not necessarily a bad thing. You're going to increase readmissions. We actually look at that as a good thing in the beginning, and I'm going to give you some tips and tricks if you get some pressure on this. So we know that blood pressure initially decreases and then increases, right? From our own state-level data, we know a lot of the maternal deaths related to preeclampsia happen in that immediate postpartum period. So it's a critical time. That's why we're working on sending folks with blood pressure cuffs. That's why we're working on follow-up visits so that we can intervene. You intervening by readmitting is helping prevent those maternal deaths. So it's not a bad thing, right? If you prevent a stroke, an intracranial hemorrhage, or a death, that is so much better than a readmission, all right? If you need ammunition with your hospital, there is a publication here at the bottom, which I have referenced, which is a position statement from the Society of Maternal Fetal Medicine explaining why postpartum readmissions are not a good quality metric. And here is their list of why we don't necessarily want to prevent it. However, some other things that we talked about. If you are noticing an increase in your readmissions, here are some things we suggest you do because you might be able to prevent them. Number one, go back through that chart, and you want to be looking in the delivery admission and in the postpartum period to figure out what happened. You want to make sure that is optimized, including, we now have evidence that if their blood pressure is greater than 150/100, they should start on an antihypertensive, and recommendations are not to discharge them within 24 hours because they have an increased risk of readmission. Each subsequent blood pressure increases the odds ratio significantly. So that is why that's a big deal. So if you're sending folks out with 150s over 100s, starting them on an antihypertensive might prevent that. The next thing is, do you schedule them for that follow-up visit, and do they go to it? And if they don't, that's where your work needs to be. Again, that's the entire part of this simulation tomorrow. Are they not going because of transportation? Are they not going because they can't see that provider because their insurance doesn't cover it and they weren't seeing them ahead of time? Have they risked out of where they were being seen before? So for example, were they being seen at a low-risk federally qualified health center and now they had severe maternal morbidity and they can't go there? And these are all of the pieces to kind of figure out the getting to the postpartum visit, which ideally should prevent the readmission. And again, that's the entire point of the activity in the afternoon. And then, this is my hospital guideline. So that TCH team, it's gonna look really familiar. It's the same one that we use. We use at 2 of our hospitals. And it includes algorithms for who you start antihypertensive medications on when, who can be discharged when, and what you do in the reevaluation process. We're going to put it on Basecamp. I've shown this a million times. It exists in a number of different forums, but it's going to go with these slides. Copy it. We copied it from this publication. Again, that's the part of AIM is to share seamlessly. But this includes, in the postpartum period, who gets an antihypertensive, when you can send them home, what's the management in that time period, if they come back, who gets readmitted and who doesn't, and then we also have guidance for when they come to the postpartum visit, what should be happening. And that's all with the goal of trying to reduce readmissions. So sometimes you need to standardize this piece. Many of you expressed the outpatient piece is the hard thing, and I agree. And that's where the bridge between inpatient and outpatient and those care transitions is such a vulnerable period of time for our patients, and that's the piece that we all need to be working on to reduce readmissions. So again, really think about that as you're doing the activity in the afternoon. We're gonna let you walk through that and make some mistakes, and we hope that then you take it back and think about what you need to adapt. When you meet with the community partners, there are partners that do home visits. Get their information, figure out who you might contact in your area, bring home visits to your program to help with that so that they are getting that if they can't come in or follow up with their postpartum visit. So again, this is a massive question that you all have, but there's a lot that we're going to try to share with tools to help. All right. Again, all of these are in there that our team created and adapted from other things that you all can have. And then finally, some questions on blood pressure cuffs. So sorry if you've heard me say this before. Blood pressure cuffs are durable medical equipment. You cannot give a prescription to a pharmacy and have it filled. It is DME. Some insurance companies cover it. Chip Perinate does not, Medicaid does. There are forms to fill out for DME, and you have to use diagnosis codes that are going to allow it to be covered. These are the codes that you would use. They do not have codes for gestational hypertension, so you use these other codes. Then you have to connect the patient to a DME company like Breast Pump Depot, to be able to pick it up. You can make an arrangement to have it in your hospital if you have enough folks. The gap remains our Chip Perinate folks because DME is not covered. Here are some examples of what you can do. So many folks are starting to get funding to be able to hand those to patients, but here are some other things that you might be able to use to do that. I heard a lot from people that they were doing innovative things with the postpartum follow-up. Does anybody want to share in 2 minutes something that they've done? We will keep bringing this back, but all of this will be available to you guys. We didn't want to ignore it, but we wanted to make sure you see and have some tools for it, but that's a big part of the afternoon. Okay, Dr. Morgan. There was a question about, do you need to validate a severe blood pressure before treatment? Do you want, and we're gonna kind of attach it to the severe hypertension metric review.
Yeah, just really quickly, who loves the severe hypertension treatment metric? Everyone's favorite, right? It's really hard, honestly. So let me start off by saying there is I'm going to tell you what SMFM outlined as their metric for measurement. I did this in Abilene, and I think I made everyone a little bit confused. It's a guidance. If you want to be pure, you can follow it. You can also adapt it, but be consistent. So they were actually holding people to a higher account than what this metric does. That's fine. If your hospital is doing that, then please don't worry, oh my gosh, we're not. We're all, I know Sue reiterates this, so does Julie. We may all be measuring just slightly differently, but as long as you're doing it we're all mostly on the same path, and as long as you're consistent in your hospital, you're going to see your change. That's what we're really driving for here, is improvement. So if I say something and you're like, oh my God, that's not exactly how we're doing, that's okay. If you're holding people to a higher account, if they don't check it in 15 minutes, then you call that a fallout, even if you check it again sometime within the 60, and that's fine. Like, good for you. You're really like pushing them hard. So I just wanted to show, this is an example, again, it's from the Society for Maternal Fetal Medicine, the quality metric that they put out. It's a good reference. Again, you don't have to follow it to a T if that does not work for you or you want to modify it in some way, but it is a good thing to go back to. This is just an example of not whether it qualifies this is a denominator, it's a persistence. Does this count as a persistent hypertensive event? And what I wanted to show is simply the burden of proof is on us. If we don't check it within 15 minutes, they call it persistent. And it doesn't matter, it might not have been, but the point is it's on us to check it. So the only one that did not count as persistent in here is that first one in green. All the rest of these are persistent episodes. Now, that doesn't say whether they would qualify. Some of these, they were treated, they had resolved by 60 minutes, so it's not that. But they would go in as a part of your denominator. And again, some would be in the numerator, depends on, we won't go through every single one, but I just wanted to point out that what they basically have said is, if we don't check it in 15 minutes and prove that it's not severe, then it's considered a persistent episode.
And we go point by point through this document and the measurement in the data calls if you want to go back and listen to them again.
Okay, next one. And again, this is just the measure definition. Again, I wanted to point out, I think everybody's got this by now, but we are only using the first episode of severe hypertension. Not because the other ones aren't important, it's readily, it would become so overwhelming and confusing if we counted every single episode. And so for simplicity, we are asking you to report on the first episode of severe hypertension that your patient experienced. However, if you don't look at the other ones, it is true, you will probably miss opportunities for improvement. So please don't feel like, oh, we can just ignore it. If we treated the first severe one, we're good. Because there are definitely going to be fallouts, and I think some of those patients, I'm sure you guys have experienced this, that have repeated episodes, those are the really challenging patients. And so it's not to say that we want to fall down by not looking at the rest, but for the purposes of reporting, it's just the first one. Okay, next slide, Carrie. You want to say
I
something?
thought we were asking for every episode.
What?
We're going to come back to that in a second. We have a difference of opinion what we're asking for. Sorry, just not to confuse folks.
So the misses are defined. I just want to really quickly point out how we define misses. So let's look at this first one here. So would this patient qualify in your numerator? Do you think she was successfully treated? So we agree, first of all, is she in the denominator? Is she persistent? Did we check it within 15 minutes and agree that so remember, the burden of proof is on us to check it within 15 minutes and prove that it wasn't persistent. So was it persistent? At least again, you want to do it different, that's okay, but at least by the measure it was. Did we treat it, or was it not, would it go into the numerator? Did we successfully resolve the episode? Within an hour, within 60 minutes of the first severe range there. Yeah, we did, right? We didn't do anything, but it was non-severe within 60 minutes because it starts back over. Carrie, will you?
I'm confused. Sorry. So checked it at 7, it's severe. Don't check it in 15 minutes. It's now
persistent.
non-severe. Don't check it again for an hour, and at 8:07
No, we did check
it's
it
severe.
again. We checked it at 7:35. It's not severe.
Okay.
You don't agree? Mm-mm. That's what the measure.
Sorry.
It is persistent, but within the hour, within that 15 to 60 minute range after the first one, so we counted it as persistent, it was a recorded non-severe and there was not another severe range recorded.
Can we just move forward and come back? Okay. Sorry, guys. Jamie, we're going to talk about severe hypertension follow-up? Or these other slides? Okay. All right, severe hypertension management prior to regional anesthesia. You can, go ahead. So there was a question about people not bolusing epidurals or not wanting to do epidurals and treat severe hypertension because of the concurrent concern for hypotension, and that was a barrier folks were hearing from anesthesiologists. So that is not the recommendation, and the Society of Obstetric Anesthesia also has a statement that they don't endorse that. So if you need to bring that back to your anesthesiologist, here was a tool. Go ahead, Julie.
So we had comments about traveling the Friday before Thanksgiving. We hear you. We also know that this is a very full and active day. And so we're going to let y'all out no later than 4 p.m. Please stick with us for the all of the breakouts and the 15-minute wrap up at the end, and then we'll set you loose.
All right, Brooke. So there lots of questions about which medication, when you change an escalation, when you start over, et cetera. And Brooke's going to go through pieces of this to help you guys.
This is a part of the sharing and stealing and all those kinds of fun things here. So this presentation is largely taken from Dr. Hill's presentation. Dr. Hill stole this presentation from Dr. Foley, who's one of the folks who does the critical care course in Arizona. So let's see, I'm gonna probably do this. That's probably better for me. So we're going to go through some very basic things. And before we get started on what is the best medication to do, I want you just to remember that any one of the 3 medications that's on your pathways are okay. So if your doctors are choosing any one of those 3, yay, that's a win. We're treating things. This is going to kind of give you some nuanced things, and some of it's going to simplify, some of it's going to make more difficult. So just kind of bear with me as we go through these things. Starting with some very basic things. Severe preeclampsia, what are our definitions for that? Systolics of 160, diastolics of 110, at least 4 hours apart, but the important thing is, if you have treated with medication before that time, you can now flip it into the severe category. That's always one of the things that gets confusing, especially at academic centers. It hasn't been that 4 hours yet, okay? If you've treated with medication because of severe, thank you. I've already got my 15-minute warning here, so we're gonna see if we can get through it. So, wow, that was quick. So we're gonna see if we can get our way through it. So, okay, why do we treat? We treat because of stroke is the big one on top of that list, right? But there's a whole list of not great things. We don't want them to seize. Abruption, acute heart failure, myocardial infarction, renal impairment, post-op bleeding, hypertensive encephalopathy, all things that can happen because of severe range pressure. So we want to make sure that we're getting that treatment done. Doesn't matter what their source of pain is, treat the bleep blood pressure. That's an Elliot Main quote, so I'm stealing that one from him. But basically, that's the MQCC for those of you who don't know Elliot Main. But basically, treat the severe range pressures. Doesn't matter your source. Treat them, figure out what's going on, try to reduce what's going on after that. All right, what is the best one? Let's go ahead and take a look at some of these things to get this kind of figured out. I'm going to nerd you out a little bit here. I'm going to go back to what we're doing as far as our adrenergic symptoms that are here, or areas that are here. So what do our adrenal drugs, what does our adrenal cortex do here for us? And then what do our medications do that basically make a block in this? Vasoconstriction, blood vessels clamp down. Sympathetic tone, we'll talk a little bit more about that, but not a whole lot. Heart rate contractility, heart squeezes harder and faster. And bronchodilation. When we talk about things that are beta blockers, we'll talk about that a little bit more. You can see that that's kind of your beta sort of things. Labetalol may not be your best choice in a bad asthmatic. Okay, because there's a bronchodilation effect with that. When we block that, that gives you bronchoconstriction, okay? So it may not be the best thing there. So it's just kind of a lot of things to kind of be thinking through as far as things go here. So you have your alpha, which is going to be primarily your vasoconstriction sorts of things. You have your betas that get your contractility, and then the heart rate, or the lung issues that are there. If we think about what we do, we use things that are calcium channel blockers, don't really affect this area, kind of another way of doing things, but I will tell you that those are, well, we'll get to it in a little bit later, but those are very good for vasodilation with less heart effect. Your beta blockers are going to be blocking that we just talked about, your heart rate, your contractility, and that's going to be your bronchoconstriction. And so we're going to go through a few more things here. What are the medications that we use? There's our big 3, okay? So you can take a look and see labetalol is a beta blocker with some alpha. The hydralazine is a direct vasodilator. And your calcium channel blocker is going to be one that also is largely, like we talked about, vasodilatory with less heart effects. All right, so let's go back to just kind of what creates blood pressure to start out with. Blood pressure is a product of the flow and that resistance. So when you have resistance, that's going to cause, if you increase your resistance, that's going to take your blood pressure up. If you increase your flow, that's going to take your blood pressure up. Those are your components, okay? So what gives you increased flow? If you have an overloaded patient, you've taken your box, if you want to think about your box, you've taken that box and put a lot more fluid in there, that's going to increase your pressure. If you increase your cardiac output, the heart rate goes up, or the stroke volume goes up as far as they're being able to push fluid forward, that's going to increase your blood pressure. Vasoconstriction, lots of things can cause this to go on. Somebody that comes in that's used cocaine, vasoconstriction. Our patients that haven't got their epidurals that are in pain, vasoconstriction. Hypoxia or hycarbia. If your patient is not being well ventilated, guess what? You got some issues that you need to be looking for. If your patient has had a stroke and has a bleed in their head, they're going to have an increased cerebral pressure. The body is going to upregulate that. You're going to get vasoconstriction, trying to get that blood pressure up to get perfusion of your head. Other things on the other side of things, you got your kidney functions that are there. Don't forget about thyroid storm that can sneak into the picture. So hyperthyroidism can be a problem. Preeclampsia, which is what we've been talking about for the majority of the time here. And then our favorite zebra, pheochromocytoma, where you have adrenal tissue that's other places that are sending off adrenal adrenergic sorts of impulses that can go on. It can give you really high, hard to control blood pressures from time to time. Okay, so the Gestalt, a great word in Germany. I lived in Germany for a chunk of time, so Gestalt, a great word. Basically it means a kind of a basic thought of what is our basic understanding of this. So let's take a look at two things. Systolic blood pressure, diastolic blood pressure. The systolic blood pressure is going to be your stroke volume and that vasoconstriction, like we talked about there. The vasoconstriction is what you're looking at for the most part on your diastolics, okay? Your pulse pressure is just the top one minus the bottom one. So your pulse pressure is what pressure is being generated between those two. So you have the resistance that's there and the pressure that's being formed to overcome that resistance. That is your pulse pressure. And your stroke volume is 2 times that. So how much fluid is actually flowing forward is 2 times your pulse pressure. Okay, so this is the part that is shamelessly stolen from Dr. Foley, the stay alive, drive 55. So if you can kind of think about that, I don't think there's any speed limits in Texas anymore that are anywhere close to 55. But basically, back in the old days, I still remember when we were all trying to conserve gas back in the gas sorts of shortages back when I was a kid. 55 was the speed limit like all across the country. 55 is the magic number we're going to kind of talk about, and we're going to go through that here now. So let's take a look at this Gestalt that we're talking about. A patient comes in, 160s over 110. 160s, not overly high as far as that top number goes. 110, we have significant vasoconstriction that's there. Your pulse pressure, 50. We're not above that 55 here as far as things go that way. Our primary problem is resistance. So our vasoconstriction that's going on there. And so what do we got going on there? There's our causes that we were talking about. Second Gestalt patient that comes in, 190s over 100s. Okay, hyperdynamic. Either lots of fluid going on there or a lot of contractility going on there as far as things go there. Your vasoconstriction is kind of moderate in this case. Pulse pressure, 90. You've got an increased stroke volume that's there. Increased flow is our major issue that's there. All right, so with that increased flow, what are the ways that we can treat that? You've got the increased flow from the heart rate being contracting, either too much or too fast. Best way to stop that, we go back to that picture from the very, very beginning, beta. We want a beta block, right? So our beta blockers, labetalol, may be a really good one for this particular sort of a thing here. You also may be hyperdynamic, hyperfluid there. This is one of those weird things back when I was in training, the long time back, we talked about the intravascular space being depleted in a preeclamptic patient. Still a true principle you need to remember, but probably not pertinent for this particular patient because of their hypervolemia. So the thought of a Lasix in this kind of a patient used to be heretical. Maybe it's something we want to be doing, is offloading some fluid in this case. All right, resistance, that increase in catecholamines. We talked about a lot of the reasons that can go on. There's just kind of those examples that we went through again. With the vasoconstriction, want to go back through, remind you what our medications are and where they fit. Hydralazine, direct vasodilator. Nifedipine, mostly vasodilation as far as its effect goes. Labetalol, beta blocking, so contractility, heart rate sorts of issues, a little bit on the alphas. All right, so when we start talking about what do we choose here, what are our general principles? You got to go back to some basics here. Okay, we need to know what must possibly causing things to go on. History and physical examination, our hemodynamic status. Sometimes that's going to require ICU monitoring to actually figure out what that is with central lines, etc. The gestalt of blood pressure, kind of what we talked about there, the contributing factors, and is it flow, is it resistance, is it both? All right, we want to select a drug that best matches that patient's needs. Let's get back to that for time purposes. So reducing the diastolic pressure, we want to get the pressures down. We don't want to be taking them down too low. So what we're trying to do is get down to kind of that 140s over 90s as a baseline. We don't want to be taking things from very high to very low because you've had a patient that's been used to having perfusion that's going on over that period of time. We don't want to overtreat, and I'm sure you've all seen it. When we overtreat, what happens to that baby tracing? Not so great, right? So we start to get those lates because we're not getting the good perfusion to the uterus like we like to have. And we don't want to make sure that if we've got somebody that's got a stroke, we really have to be careful about undertreating because now you're going to take the flow to the brain. So lots of factors that need to go into your thought process here. So what else can you use our pulse pressures for? Is Dr. Hill likes to joke around about how you can look really smart to your anesthesia guys as far as this stuff goes. But basically, one of the things that's very good for us, we don't always see the bleeding in our patients, do we? They can sometimes be trapping up inside a uterus that's expanding. They can sometimes be outside of the uterus and going in places where we don't know it's there. If you have a narrowing of the pulse pressure, that can be a sign that you've got blood loss that's going on in other places. Reason for that is your body says, oh, I'm losing blood. Its responses are going to be to increase that heart rate to try and keep that flow going through. And also, you're going to constrict your blood vessels initially to try and get that pressure up, to get that flow going around in the face of less blood being in that tank. The tank is less, the body's going to increase that pressure to try and get what's left in the tank to be circulating. And then, of course, once you get beyond that, then you have the major tank. And for our young, healthy women, we know that this will happen, and then when that stops happening, it could be a very abrupt plunge into not good places. And then assessing for the spinal or epidural. So if you've got somebody that's got that really broad pulse pressure that's there, you may not need as much of that fluid that's there. They may be already overloaded if you've got that large pulse pressure that's there. You may not need to give as much of a bolus for that. And if you've got the narrow pulse pressure, you may need to be actually giving more. All right, we want to give a drug that gives you minute to minute. That starts to get into our ICU sorts of treatment. We can't really do minute to minute with what we've got here, but all three of the agents that we use are fairly short acting and are ones that we can control well. That's why they're on the algorithms for what we've got going on there. And you want to know how to, or what the effects are like we've talked about up to this point so far. So I got my little warning back here. We're going to kind of buzz through these cases fairly quickly. Bottom line's on this one, 165 over 110. This is more vasoconstriction or more hyperdynamic, more flow? Flow or resistance, would you say? Give you a cheat. So this is more of a resistance issue, right? Jim was very sneaky on this one. He puts you right at the 55. So I was like, oh man, that's not very nice to do that part of things. So basically, you're looking at more of a resistance sort of an issue, and your best ones are most likely going to be your calcium channel blockers or your direct vasodilator. So this may be a patient where your hydralazine or your nifedipine would be your better choice. You can still use your labetalol, okay? I just want to make sure people are aware. A lot of people, almost everybody out there loves labetalol, right? Everybody's kind of defaulted to labetalol at this point, so you can use it. It's not a problem for that. It just, those other ones may be a little bit more effective for you here. Now here's our other one, 210s over 110s, clearly above our 55, clearly in that hyperdynamic or flow sort of a portion of this. With that one, you got your flow. You probably are going to want to get your contractility down, may need to get some volume down, and this one is going to be your beta blocker. So this is where your labetalol would be your best choice as far as things go here. Okay, so summary points. Remember, 110, 160, remember, treat the pressure. Treat it quickly. Those are our main things that we want to be making sure people are getting there. We want to remember the severity of what's going on there. Also, one of the things that came up as questions that we wanted to just quickly throw out there as part of this presentation. Magnesium is not an antihypertensive medication. Yes, it is true that if you give magnesium in higher doses, you may get a small drop in your blood pressure. It is not meant to acutely treat a hypertensive emergency. So there's still some folks that are out there that still may have that. That's something that definitely needs some education if that's the case. The other thing is PO labetalol is another thing that can get very easily confused. PO labetalol is not quickly acting like our IV stuff is. So yes, labetalol can be used longer term, but it should not be used for our acute responses to a hypertensive emergency. So as far as increased flow goes, beta blocker is going to be your better choice. It's kind of a gestalt. Increased resistance, your alpha or your calcium channel blockers are going to be your better choices that are there. And basically the big thing, I think that gets us, yes, that gets through that. So questions? Okay, I think we got that done.
Hello? Oh, wow. You guys ready to get started? Yes? Hopefully everybody got a little break. Hopefully this next session is going to be enjoyable and enlightening as well. So we're going to talk about integrating cognitive bias assessment into case reviews. So before I get started, just a general overview. We're going to go through a little bit of background. Then you guys are going to spend a whole lot of time reviewing a case of a simulated patient, looking for elements of bias and also trying to identify some of the social determinants that might have affected the patient's outcome and care. And then we're going to debrief together after you have a chance to do that. So just a little bit, again, we're just going to go through a little bit of background before we get started. So case review, I just kind of want to frame where case review fits in the quality improvement cycle. So, this may not be how everybody's flow works, but just as a general matter, we're getting a lot of information and data from different places as we're trying to decide how to prioritize our quality improvement and safety efforts. So of course we get indicators, hospital tracking. I'm sure obviously we know a lot about indicators from mandatory reporting. And so those, when you're looking at your data, tracking and trending, you're probably going to identify opportunities there. But one of the big sort of mechanisms that we use, processes that we use to identify improvement opportunities is case review, which we usually use to filter safety event reporting as well as root cause analyses. So the way that we figure out when we have an adverse event, of course, how can we make things better? The only way to really do that well is to use case review to help elucidate improvement opportunities, themes, and trends. And that's really where then those case review findings help us to identify our gaps, and then we, from there, move to prioritizing and launching quality improvement projects. So there are a lot of potential safety event contributors. Many of these you guys are intimately familiar with. You're used to looking, when you do case review, you're looking for all of these different contributors. So things like staffing, right? Policies and procedures. Did we know how to take care of the patient? Did we have a policy? Did we follow it? There's escalation delays, right? Often we know that we've seen throughout our state that can be a huge problem. Did we not call for help on time? Did we not identify and escalate appropriately? Teamwork and communication, of course, is a huge area where there's often an opportunity for improvement. Sometimes it can be a knowledge gap or a skill gap that's identified via case review. Equipment or supplies, resources that we didn't see or didn't have available to us, and then human error, of course, can happen. But another big contributor that's often sort of overlooked is cognitive bias, and so that's where we're really going to focus today. Again, I think that teams are really facile with looking for a lot of these potential contributors and maybe a little less so for cognitive bias. So we're hoping that this session will help you tune in a little bit more to both how to look for it and then also how important it can be, and without it, how we may really miss some real opportunities for improvement in our processes and our care. So hopefully many of you had the opportunity to join the action period call in August when we talked about bias and case review. And so this is just a quick reminder. So cognitive bias, flaws or distortions in judgment and thinking and decision making. There are literally, hundreds of types that have been identified. Some of them are much more familiar to us than others, but there are a huge number of them that are out there. They contribute very significantly to patient safety events, and cognitive bias has been associated with up to 15% of adverse events and 28% of diagnostic errors. So this is just sort of showing us, I think intuitively, many of us will hopefully sort of know this graphic, but the impact of cognitive bias on decision making. So the way that most of us reason, and especially when we're talking about clinical reasoning, is that we sort of have this push and pull of two different types of reasoning that we're using. So we're using that type 1 reasoning is really that like innate, quick, automatic, it's very efficient, but it is subject to sort of that emotional influence. And it's very passive. We basically do it almost without thinking about it, right? And then type 2 reasoning is that more methodical, learned. It takes time. You have to be slow and meticulous about thinking about it. And the problem is that we're often really pulled, especially in, where everybody is busy. We've got a lot of patients to take care for, high acuity. So particularly when we're trying to evaluate patients, we're really pulled towards that type 1, right? To do things that are quick and innate to us. And so we have to be really, and it's very unconscious in many respects. So we have to really try to bring some of that into our consciousness so that we can balance these two out a little bit more. And there's a lot of factors that can predispose or increase the likelihood of cognitive bias. So fatigue, right? For example, cognitive loading, if you've got a lot on your mind, you're dealing with a lot. Just sort of how you're feeling on that particular day. Patient factors, obviously, the more complex the patient, the more difficult it can be to really sit and do type 2 reasoning. We're really falling back on some of that type 1 processing. And then system factors, right? So workflow design, sometimes we're really overwhelmed, tasks are incredibly difficult. We have insufficient information, which again will bias us towards that type 1. Processing, inadequate processes to acquire information, poorly designed environments, poor teamwork, those sorts of things really will kind of push us more towards that type 1. So we really have to, again, part of what we're going to be doing today is hopefully bringing more of this into our consciousness and then our control and our ability to kind of influence so that we can move and be more methodical about how we think about this, or change the way that we process in terms of our type 1. This is not a comprehensive list of biases by any stretch, but it is some of the more common ones that we see in clinical practice. When we do the case review, you guys all have this particular printout in your folder for reference. You can use this. If you have a computer or a phone, you're welcome to look up other lists of biases that you would like, if you find another resource. Again, I think that these are some of the more common ones we're going to see, but there are clearly many other ones that that have been identified, and you're welcome to use whatever resource is helpful. You also have this sheet, so we're going to be looking for stigmatizing language, which again is another form of bias transmission. So these are some examples of stigmatizing language and how that can be interpreted. And so this is also going to be in your folder for reference. Again, you can look, there are other resources that you're welcome to use if you find one that you like better. Before I tell you, this is, unfortunately Sue's not here with us today, so I'm going to do a poor job subbing for her, but Sue really wanted to give you a couple of tools, improvement tools that you can use as you're going through case review that might help you to identify, both factors, other factors, some of the processes, the resources, the human factors, all the different things, but that also might help pull out some of the bias elements. And so just how can we organize when we're doing case review? So most of us, of course, are doing, I know you guys are doing a ton of case review in many cases. Now, you're not always going to have time to use these improvement tools, but they can be really helpful if you either identify a number of themes, like you have cases that are really, you're getting the same sort of outcomes, so help to organize your thoughts if you really need to sit down deliberately because you're seeing patterns. And then RCAs are another place, if you have a really significant case, really, of SMM that you want to review, or a case that really has a lot of opportunity for improvement, then you might really go through this in a deliberate way. But admittedly, if we did this on every single case that you're reviewing, you'd never do anything else, which you probably feel like you may not have time to do anything else anyway. Because to do a good case review, which we're going to spend probably 45 minutes-ish, to an hour doing this, and I think that it takes a long time. This isn't an overly complex case, but there's so many elements to identify, and so doing a good case review takes a long time. So the two tools that I'm just going to introduce, and you guys hopefully have seen these before, are cause and effect diagram and the 5 whys. So hopefully most of you have seen this fishbone cause and effect diagram. Have any of you, or do any of you use fishbones routinely? Awesome, a couple. I'm impressed. So for those that have not seen this, we're going to go through in a little detail, but basically you look at your effect, and in this case, usually your outcome of interest, and our cases are usually coming from SMM and other adverse outcomes. So your effect is going to go at the head of your fish, and then all of your fish bones are going to be your causes that you identify that were contributors. So I think it's just a nice pictorial relationship for those of us that have more of a visual, case review is often, we're going to have you use a case review form. You're going to identify some of these same elements, so it's just a different way of organizing it. And it illustrates the complexity of the variables that interact. So the head, again, like I said, is the indicator, the issue, or the problem, and then our branches are the many potential contributors. And it can be used to explore factors. We're using it in this case sort of for problem solving. We want to know, we have a negative outcome, and we want to know what were the potential contributors, where can we make an impact, where are quality gaps. And again, this is the way that you would do it if you, and you guys do have blank fish bones in your folders, so if you want to experiment with this, by all means. Usually the categories that go on the different bones of the fish are typically are going to be materials, methods, equipment, environment, and people. If those don't fit what your case you're reviewing, you can always change them up. And then one of the things that Sue has put on here, which I'll just skip to here, is bias should and could be your tail of your fishbone. So this is really something that should be part of all of our case reviews at this point, so it's been a little bit under-recognized, but you're going to see, again, when we go through this case, that it's incredibly important, and that without it, that we would really miss a lot of opportunity to impact care for this patient or a future patient if you don't look for those cognitive biases. So this is just an example. Again, we're going to be reviewing a case of a patient who experiences an eclamptic seizure. So some of the things that you'll see as we go through, medication availability is a theme that we see. There's certainly elements of bias. So this is just an example of how you might start to organize your fishbone. The other tool that she talks about is the 5 why tool. Anyone familiar with that one? Anyone use that? No one? This is something that we use for our RCAs, and I think it's a really, it can be incredibly powerful, because I think if you aren't, and the fishbone can help you get there too, but you really want to keep asking why, because sometimes the answer that you come to first is not really the root of the problem. And the point of the 5 whys, it really does take 5 times of asking why on average to be able to get to what really caused the problem. And if you stick with the superficial the first why that you come to, you're really not going to get to the heart of the issue. So this is a really good example. So this is a patient, she received a wrong medication. So in this example, the reason she received the wrong medication is because the nurse didn't complete the patient identification. So if you stopped there, you would say, it's the nurse's fault. She didn't complete the identification. Number one, I think it's always hard when we're looking at analyzing cases, we should not be, we're looking at systems and process. We're not looking, while human error can come into it, what we really want is to try to identify the systems issues that we can fix. Sometimes there are human issues that need to be fixed, but most of the time we're interacting with a system, and it's the system that's failed us. And so in this case, if you just stopped here, though, you would say, it's the nurse's fault, which would never really be true because she's working in a system that has failed her. But that's why we want to be careful to keep asking questions. So why did the nurse not complete the patient identification? It's because the patient didn't have a wristband. Why didn't she have the wristband? It was removed from for a procedure and wasn't replaced. And the reason was that the printer for the wristbands was not working. And apparently there was, in this case, the IT support was not provided to fix the wristband printer. So, this is it's not a silly example, but it's just a random example. But you can see very clearly, it illustrates that you started here thinking it was the nurse's fault, and we ended up, we've had a printer problem and we don't have enough IT support. So those are very different places in terms of where do we need to, if we want to prevent this from happening again, then we're going to address this in a very different way. And so I think it's a really powerful tool to try to get to the root of the problem. So as you guys are going through your case review, feel free to experiment with either or both of these tools. As Sue wants to remind you that the cause and effect diagram can be a really great way to organize ideas. She suggests, especially if you're doing something like you have a more major issue, a recurrent issue, a really big case that has a lot of moving parts, that sticky notes can be really helpful because you can move them around and you can take them off and add them on and you can color code them. So if you want to experiment, please, you have some tools inside of your folders that you can use as you're going through your case review. Okay, so let me tell you what we're going to do here in terms of session logistics. So you guys have a printed case in your folders. Everyone should have one. It's the case of Tiffany Johnson. And I'm going to give you, if you want to use, there's an electronic version. So you can use this on a computer. I'll show you URL in a minute. Or if you have a phone, you can use your a QR code. If you happen to be using an electronic version, there's a chart navigation page where you can click to get to all the different areas of the chart and hyperlink to them. And then there's on the bottom right of every single note and every single vital sign, you can hyperlink back to your navigation page. So it's a little bit easier to move around. As you go through this, you're going to practice, again, if you want to try using the cause and effect diagram or your 5 whys. You're going to fill in, you should also have a blank form that looks like the form here on the bottom right. It's from the council, adapted from the Council on Patient Safety. And you'll notice that the first kind of page and a half are filled out for you with some demographic information about the patient. This is often what, and we'll talk about this when we debrief, but I'm sure many of you, somebody might be extrapolating that data for you, just some of that basic information. So often you'll get a case review form that looks somewhat like this. So we want you to work in your teams to go through this case and fill out this case review form collectively. And then the case review form has a lot of questions, and it really asks you to look for evidence of bias, as well as stigmatizing language, and then also social determinants. So what social factors may have played into the patient's care and outcome. Okay, let's see. Okay, so this is what the form looks like. Hopefully everyone has one. You can fill out just one per team or however you guys want to do it. but you're going to work through this together, discussing the case for about the next 45-ish or what? Everybody find everything that I've talked about? Yes? Anyone having problems, doesn't have it? If you want to use the QR code here, if you want to look at it on your computer, there is the URL. And again, work together, discuss amongst yourselves. You also have your aids, those two, again, you can look up your own biases, your own cognitive bias list, your own stigmatizing language resource, but you do have a couple to use to guide you to help identification. And we will give you, Julie, is Julie here? Till what time? How long do we have, Carrie?
I'll look and tell you. Give me one
Okay.
second.
We'll tell you in how long you guys, about it. We'll check in with you in about
1 hour.
1 hour. I know that seems like a lot, but most of the time, I'll check in on you in 45 minutes, but most of the time, people have wanted or needed more time to finish their case reviews.